So, Helen Parker, a director at Practice Partners, working very closely with the Vitality Partnership. Thank you for coming along. And maybe you could tell us exactly what the Vitality Partnership is.
Yeah, the Vitality Partnership is a single GP partnership, so it's a single legal entity that through merger with like-minded practices and acquisition of practices for GPs who are retiring are developing their partnership to be a large-scale healthcare primary care provider organisation, aiming for a list size of about 100,000 patients.
Okay, and what led you to develop this model of primary care?
Well, it is a new organisational model for general practice, and particularly for inner city urban general practice. And part of the driver for that was a recognition that the current system of general practice, and particularly in inner cities, of very small, fragmented general practice, was not conducive to large-scale transfer of hospital activity into a primary care setting. I think it's one of the reasons why we've not been successful of that over years, partly in response to changes in general practice and the increasing demands on general practice, particularly from having to demonstrate quality, having to do more for less, that some smaller practices are struggling. And actually, as a new large organisational model, they will probably be a bit more robust and sustainable in the future, together with also a recognition, and this is what GPs were telling us, that actually the career structure in general practice is quite flat. You know, you're either a salaried GP or you're a GP partner. Difficulty in specialising if you've only got a list size of 3,000, 10,000, and actually an organisational model akin to lawyers and accountants and how they organise themselves was a different way of providing general practice.
And then, having built that larger partnership, can you tell us about some of the ways in which you are now working with specialists?
Yes, well, one of the opportunities that creating a larger list size provides you, and we're about a third or halfway to meeting that 100,000 patient target, is that you are able to develop the infrastructure and organisational capability to widen your clinical service provision. So in addition to the core PMS, GMS services, what we've started to do is to build up a clinical service portfolio of the more specialist services in a community setting. So we've started to work with consultants from the Acute Trust to deliver community rheumatology services, dermatology services, gynaecology services, and now Vitality Partnership have got their own X-ray service.
And what's the balance between the work that the GPs do and the work that the specialists do within those services?
Well, predominantly the Vitality Partnership is setting out to be a primary care provider, and what they've done initially is capitalise on the skills that they already had in the partnership. So they had gypsies already with dermatology interests and rheumatology interests who were delivering quite a lot of that service specification. What they've done is brought in consultants to not only provide, for example, one session a week to those services, but also to support the training and education of GPs working in the partnership. So predominantly the GPs are delivering most of the community-based services that you'd expect them to do, but with a sessional basis with the consultants.
And I think gypsies are GPs with special interest in those clinical areas.
Yes.
Okay. And in what ways do you think commissioning can support the goals of the partnership?
Well, this is a political tension, isn't it? I think one of the things that we're experiencing in terms of developing that long-term plan to become a relatively large-scale primary care provider is taking the risk of putting investment up front. So, for example, employing specialist nurses to support those specialist nurses, developing relationships with consultants, buying facilities, buying equipment. If commissioners were willing to engage in longer term contracts than they are at present, that would be a big help for us. I think supporting relationship building and relationships, particularly between not only the GPs and consultants, which are quite good, and actually sorting out clinical pathways and how the services would run is not the barrier. It's around sorting out some of the barriers to shifting services out to the community, some of the funding barriers. I think if commissioners started to look at those between, particularly for foundation trusts and general practice providers. And it's the age-old question of how you unbundle that tariff.
So are there any other services that you're looking to work with in a more integrated way?
Yes, as well as trying to integrate the primary care and secondary care services within one organisation, working in partnership with the consultants. Part of our business plan is also to create integration horizontally. And one of the things that we feel is that the GP registered list is actually not exploited enough in this country, and we're in discussions with dentists, for example, about how we can bring dentistry, particularly in an area like Birmingham where a lot of people aren't registered with a dentist and don't have preventative oral health, about how we can integrate with the other independent contractors. We're in discussions with a pharmacist. What we'd also like to do, of course, which I know a lot of people look at, is to look at how we can better integrate through that integrated care organisation services like community physio, community nursing, and look at how we can deliver those in a far more integrated way than some of the fragmentation that we see at the moment.